Dear friends and colleagues in Hong Kong, it's a great pleasure to once again be back speaking to you at the Jockey Club End of Life and Community Care Project. Special thanks to everyone in Hong Kong who are working in these difficult times, and also for those suffering in Ukraine. Presently, a real difficult time for everyone, and really points up the importance of the support we can give to people at the end of life and those who are bereaved. We're seeing such a huge loss of life from COVID, and now from war and violence in our world. So the better we can become at helping those facing end of life and bereavement, this is something that's becoming more and more, I think, of a priority. Anyway, I'm Dr. Stephen Connor, the Executive Director of the Worldwide Hospice Palliative Care Alliance, and we are an alliance of organizations, about 400 organizations in 102 countries worldwide. And we value Hong Kong as part of that community. I've been working in palliative care for now somewhere about 46 years. So anyway, we're talking today about end-of-life care and bereavement care in the COVID-19 context, and some recommendations we want to share with you about how countries can more effectively respond to the kind of challenges we're seeing in our world. So first of all, no conflicts of interest to disclose, other than I have lots of interests, but not conflicts of interest. Interest particularly in hospice and palliative care for those, increasing access to care for those who don't have access. In our time together today, we're going to talk about mainly three topics. One, to share with you what we know about the status of the availability of palliative care globally, and support for the bereaved worldwide. And the two are linked in many ways. We'll talk about the impact that COVID has had on end-of-life care and bereavement, and then those who are bereaved afterwards, the impact that the pandemic is having. And what are some recommendations, finally, for end-of-life care and bereavement care? Mainly for policymakers, but I think also as we develop programs, clinical programs for support for those who are bereaved following a death from COVID or from any of the other many conditions, non-communicable disease, and some communicable disease as well. Joe, so we really there's a lot of death. It's well over 1 million people per week who died, and you can see it from this little graph. Or we have about 56 million people die, and this is not including COVID, so it's probably now closer to 60 million. So it's well over 60 million deaths annually that we're seeing on our planet. So this is a huge number of deaths per month. Almost 5 million per day, over 150,000. Just wrap your head around the fact that that many people are dying, and that rate is going to go up in the coming years and decades, particularly with the baby boom generation aging and dying, the post-war baby boom, which was called the epidemiologists and statisticians call it the pig in the python. It's sort of this big lump that's moving through the cohorts of humanity. Anyway, we see that based on the work that we've done with our colleagues, Felicia Knoll and others, we developed the Lancet Commission methodology for determining the need for palliative care. We'll talk more about that as we go along, but we are at about 60 million people, as we said, dying, at least half of those needing palliative care. We'll talk about who's included or excluded from that number, but at least around 26 million people dying each year, most of whom have non-communicable disease. About almost 70%. So nearly 80% living in low and middle income countries. That's where the need is, not where the services are, but that's where the need is. Mostly older persons, over 2/3, over 50, which is in some countries you could be feeling pretty old at 50. Otherwise, many other countries you don't feel so old at that age. But anyway, we also include children. We can't forget the children that are included, and those deaths are some of the most difficult for families to experience and then to deal with afterwards. We always care for family members when we care for whenever a patient receives palliative care. The family is also receiving palliative care. They are as much our patients as the ill people that we care for. So, and usually in terms of caregiving, that's at least 2 to 4 people, more than that actually, in many low and middle income countries. And really we're only meeting about 12% of the need for palliative care worldwide, and lots of people dying in pain because we have severe restrictions on access to pain medication, opioids, particularly in nearly 80% of the population of the world has very restricted access to opioids. And we have the dual problem of opioid misuse in a few high-income countries like the United States, Canada, Australia, but outside of the opioid crisis in those places, the bigger problem is the lack of access to pain relief, and that's something that needs continued attention. We still are having problems making a big dent in that problem. So what about grieving? The global perspective on grieving, again, we're talking around 60 million deaths. In the US, there have been various estimates of the number of people who grieve when someone dies. It's been as high as 9 in some studies, but a careful study by the US Census Bureau found that at least 5 people were grieving for every person who died. That's 280 million people a year. We also have newly established with the American Psychiatric Association a new disorder, if you will, that is called prolonged grief disorder. That's now officially recognized as a disorder. The statisticians, Holly Priggerson and Kathy Shearer, who have researched that problem, think it's around 4% of the population, and not say that we have kind of different groups of people. Those who are resilient, could be as many as 75% of those family members after a death, or individuals, friends. And we have a small group, 5%, 4%, no more than 10% certainly, that have significant problems with grief that is not clinical depression. It's a distinct kind of difficulty directly related to the experience of losing a loved one. And then we have people in the middle who are hurting a lot, but who can get by with support groups, things like that, don't need more intensive support and care. But that's, even with 4% of the 280 million, that's over 11 million people a year who need really, really significant support. And on top of that, if you take the average number was estimated of the number of people who attend a funeral or memorial service after someone dies. It's usually around 16 people, conservatively. And if you put that together with the number of deaths, you get actually over 1 billion people a year who actually participate in a service after someone's died. And with the pandemic, those services haven't even been able to be held for the most part, which complicates the ability for persons to grieve. So we published with the World Health Organization the Global Atlas of Palliative Care. WHPCA is in official relations with the World Health Organization. This is one of our main activities with the World Health Organization. This is the second edition of the Atlas. The first one came out in 2014, and this one was just published in 2020 on World Hospice and Palliative Care Day, which we'll talk about, and really paints a picture of palliative care all around the world. And so when we think about what is the situation with availability of palliative care, which is important for bereaved people, we do have evidence that, moderate evidence that being in a palliative care service or hospice service diminishes the likelihood of complicated or prolonged grief disorder later for family members. Their hands-on involvement in caring for the patient, their ability to communicate effectively, to say goodbye, to resolve unfinished business, all of those things are more likely to happen in the context of palliative care service. And that has been significantly restricted during the pandemic, ability to actually physically care for people. People are rushed into the ICU, they're on ventilators, there are restrictions on visitation and such. We'll talk more about that. So these are the 10 leading causes of death in the world. It's still heart disease leading to essentially heart failure that is the biggest cause for palliative care, though people with ischemic heart disease, a significant portion, about a third at least of these people, the 8.7 million, die suddenly. They have a MI and they die and aren't resuscitated. So those people obviously don't get access to hospice and palliative care because they die suddenly. Same for stroke. Again, it's about a third of people of that 6.2 million that actually die suddenly. So, and these people are difficult to access palliative care because we don't have it's difficult to prognosticate about heart failure in post-stroke patients. Respiratory infection usually isn't accessing palliative care. These are people with acute infections that are treated hopefully with antibiotics. Chronic obstructive pulmonary disease, a big focus for us in palliative care, over 3 million deaths. Lung cancers, actually cancer overall, all cancers, if you put them together as a group, you'll see from our research, it's about a fourth of the need. So cancer is a big focus for palliative care, but really only about a quarter of the need. So 3/4 of the need are for people with diseases other than cancer or the many cancers. Lung, trachea, bronchus, and lung cancers are the biggest individual category within cancer. Diabetes doesn't get talked about a lot. It's actually usually often counted in other categories of illness. And we, of course, want people to get either insulin balance, but we do see people with advanced diabetes and other conditions like kidney failure, infections, and things like that. Alzheimer's is the fastest growing diagnostic category for palliative care, and Alzheimer's and other dementias. Tuberculosis is another focus, along with HIV. HIV is now dropped down underneath. It's, I think, 12th or 13th, but still a focus for palliative care. Tuberculosis, though, this is multi-drug resistant tuberculosis and extreme drug resistant tuberculosis. That's an underserved population for us. And we shouldn't forget injuries overall. Many people who survive an injury, but are so badly injured that they're going to really need palliative care. So how are we doing in terms of palliative care development? We have been doing a mapping levels of palliative care development study. We've done it actually 3 times, but the most recent one that was done in 2017 showed that only about 15% of countries had good integration. So we have the 6 measures. The first is and the lighter colors are the places where there's less palliative care, and the darker colors are where there's more palliative care. But the first level is just that we can't find anybody even interested in developing palliative care in the country. The second level is capacity building, which is that there's people working on palliative care development, but they're not yet actually delivering services. The third level is broken into two parts: isolated provision, where there's at least one palliative care operating service, but they're not actually serving very many people, to generalized provision, where there are a body of providers, but they're not well integrated into the healthcare system. The fourth and fifth levels are beginning preliminary integration into the healthcare system, and then advanced integration. So we only have about 30 countries with the advanced integration, and almost 2/3 of countries with either very limited or no palliative care delivery at this point. And we've made progress over the years with this. We have seen, we were at, I think, 7 or 8% good integration in 2011 when we did this last time. All right, so as we said, most people are older, particularly the 70-plus-year-old group is the largest group needing palliative care. 7% of children is a conservative estimate. We've done a study on children's need for children's palliative care, not using mortality data, but using prevalence data, and found that up to 21 million children a year might need palliative care approach around. It's now, with our latest data, looking around 8 to 12 million with specialized needs for palliative care that could actively need to be cared for, which is much more than the 7% in this conservative study. And for the children, a different kind of, So for adults, we've talked about some of those major categories: malignant neoplasm, 28%. HIV is a big focus for palliative care need, particularly in African region, but also injuries were added. We have the ischemic heart disease, the various, for children, well, we'll talk about that in a minute, the degeneration of CNS, dementia, very much a growing cause, but liver failure, kidney failure, all various kinds of organ failure make up the non-cancer populations needing palliative care. For children, it's a different situation. It's HIV, again, in Africa, a big focus, injury, premature birth and birth trauma. These are children, who are born, but they're too premature to survive, or have trauma during the course of their birth that usually results in a very shortened lifespan. Congenital anomalies or malformations, the trisomy kids, for instance, are in that category, large numbers. Cancer is actually, as we see from malignants, only about 4% of the need for children's palliative care. Though that gets a lot of attention nowadays. So we see that the high-income group, the high-income countries, only 24% of the need for palliative care. So over 60%, 76%, or 3/4 of the need, is in lower middle-income countries, particularly upper middle income. So we have a kind of almost like an 80-20 problem with palliative care worldwide. We have the need for palliative care is in low and middle income countries, 75% of the need, 76%, but only about 30% of the services are in low and middle income countries. We just need to reverse that ratio as much as we can. And so we had measured progress in terms of the numbers of programs per million population receiving palliative care. In 2011, we found about 16,000 services caring for about 3 million patients. But in 2017, that had increased to 25,000 service providers in caring for about 7 million people. But that, again, is only about 12% of the need for palliative care being met. So that's sort of the status of palliative care presently. We talk about what has happened with COVID to palliative care, and we did a study with our colleagues at the International Children's Palliative Care Network and the new group called PALCHASE, which is Palliative Care in Humanitarian Aid Situations and Emergencies. And we looked at some of the impact that COVID has had. We had responses from about 40 countries. Overall, we had over 3/4 of the providers responding that they had pretty significant disruption to their services. Access to palliative care was limited. Palliative care services for children and adults disrupted. Particularly vulnerable groups, refugees. Now we're seeing growing populations of refugees with no access. People not getting the care they need. Governments not integrating palliative care into their response to the COVID, even though we did get the government, the UN, to acknowledge the need for palliative care. There's not much financing. We've had programs closing, people working in palliative care being seconded to work on COVID. So the palliative care patients were not able to get care they needed, it usually at home. Palliative care not being part of the universal health coverage scheme. We found really that this was kind of a two-edged sword. Many palliative care units were closed, particularly during peak periods with the pandemic. Funding diverted to care for COVID patients. And we're expecting to see a major increase in complicated bereavement. But at the same time, I think COVID actually has highlighted the importance of palliative care. Some palliative care consults were in intensive care units. Intensivists and intensive care units really came to value palliative care. And chaplains even were getting consulted, in hospice chaplains were getting consulted a lot. And we did get palliative care included in the WHO and UN COVID health emergency responses. So we're going to talk now a little bit about World Hospice and Palliative Care Day, key messages, and these are the recommendations on bereavement care, particularly for policymakers. So World Day messages and policy recommendations. Sorry, these slides are moving a little slow. There we go. So this year, World Hospice and Palliative Care Day is going to focus on not just the pandemic, but just, I think, all of the challenges we're facing in the world today, and particularly around supporting people who are bereaved. This is going to be our big focus. This is, by the way, a preview. This is not yet public. We're likely to not have our World Hospice and Palliative Care Day toolkit finished until May. But you're getting a preview here, the theme being healing hearts and communities. There's a lot of healing needed. The experience of grief and the need to heal unite humans worldwide. These are our key messages. Global events have resulted, many events, in increased burden of grief on families, and healthcare providers are having a very hard time with both the pandemic and their own grief. Many of the people at work, we hear from intensivists saying, I didn't sign up for this, really. We're supposed to be saving lives, and what we're doing is, taking people off of ventilators. Fostering a healthy grief experience is essential to building resilience and community wellness and improving and reducing inequalities in communities. We think this is really, we're talking about a government response, but we need a bottom-up and top-down approach to these problems. We need more compassionate communities, and we really want to support the whole movement of compassionate communities. It is very much in parallel with palliative care. Palliative care is not just a healthcare service; it's a community response. We need to invest more in professional and community services to support healing and grief. These are critical issues. We also want to learn from the programs that have been developed that are effective in responding to grief in World Day. We want to share experiences and innovations from compassionate communities that bring hope and healing. And World Day will focus on stories and profiles of successful grief support programs and memorialization initiatives. So, to summarize where we're going with World Day, which is the second Saturday in October this year, by the way. It's always the second Saturday in October. And we want you to encourage you to hold events on that date. The experience of grief unites us worldwide, actually, because it's the one thing we can, that in taxes, the one thing we can count on happening is that those we love will experience the death of those we love. And that will we think it's creating an increased burden due to the pandemic and other events in the world. We want to foster healthy grief experiences with community bereavement support and invest in supporting those who are bereaved. So I'll just share with you briefly a story from this gentleman that I met in Kampala in Uganda when we were together. This is Joseph. We believe that the best spokespeople for grief and for palliative care are people with a lived experience of grieving. And Joseph was a colon cancer patient who was an advocate for the palliative care and for the hospice that he was being served by at Hospice Africa, Uganda. And one of his biggest need was simply that he could not get colostomy bags. He had to fashion bags with, plastic bags that he could find here and there. And he was terribly embarrassed, and his case was complicated because of that. But once he got into palliative care, the hospice supplied him with proper colostomy bag so that he could manage and not be embarrassed in public by having leakage and smelling and things like that. And he was just a wonderful spokesperson for the kind of support that was provided to him. He ended up dying from his colon cancer about 2 months after we met with him in this place. And this was an example of why the support that he got helped his family afterwards. They cared for him. He died at home. He had access to morphine. He was comfortable. He had if you will, a good death for him. And his family was followed, is still being followed. This was in 2019 by the Hospice Africa Uganda folks to support him in his, support them in the grief process that he went through. So what are our policy recommendations as we wind up here? We want really a national strategy to be developed by every country to support the bereaved in their communities, including primary, secondary, and tertiary support. So primary support is, doing campaigns to the public about what people experience in grieving. What are things that are difficult to deal with? What are things that help people when they're bereaved? A national day of mourning, for instance, and a good national media awareness campaign. When we talk about secondary support, we're talking about social support within the community. It's that compassionate community response for grief, individual counseling support, group therapy, group support, bereavement group supports. For tertiary, we do need to help those who are having the most difficulty with grief and are stuck in their grief with prolonged grief disorder. They can't stop grieving. It impacts their ability to function in their normal living. And those in humanitarian emergencies, we need to develop more compassionate communities. And compassionate communities are made up not just of communities. The communities are compassionate individuals, compassionate organizations, employers, having flexible leave for those who are bereaved, having education programs for employees, increasing access to hospice and palliative care programs, since we know those make it easier for bereaved families afterwards. So in summary, I would just say that we all need to pay more attention to the needs for those who are bereaved in our communities. We aren't doing enough to support bereaved people, family members. We want governments to begin to pay more attention. The only country in the world we could find that had a national policy, a national strategy for bereavement is Wales. That is a very progressive part of the United Kingdom, and that country has a very nice policy with these kinds of elements in it, where it involves community support from all levels, primary, secondary, tertiary, and funding for support for the bereaved. So I want to wish you the very best for the conference. I know this is conferences are more and more virtual. I hope someday that I'll be able to get back to Hong Kong to be with you in person. And I want to wish you every good wish as you face the challenges of our world today. And I like to say, keep up the good work, do good work, stay well, and stay in touch. Take care, everyone, and my very best wishes. Bye for now.